Hi there, my valued, highly treasured, and esteemed viewers and listeners, and welcome back to your channel of choice. My name is Dr. Nath Arwa. I am a clinical pharmacist by training and by profession, and I am the founder of Progressive Pharmacotherapy Consultants, a premier virtual clinical pharmacy institute for capacity building for healthcare workers. The virtual clinical pharmacy institute with a difference where patient safety, medication therapy management, and optimal clinical outcomes are very crucial and non-negotiable to us. Here, we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So I humbly urge you to sit back and spare me part of your very precious time to share with you some precious tips which you may find useful in your line of duty. Welcome to part 47 of our pharmacotherapy MCQ series, which majors in neurology. So first question reads, which of the anticonvulsants listed below doesn't induce the cytochrome P450 enzyme system? Is it primidone, marketed as mysolin, or is it carbamazepine, marketed as Tegretol, or is it valproic acid and its derivatives, which are available as Depaken and Depacon, or is it phenytoin, marketed as Dilantin? I'll give you 10 seconds to choose the correct answer. So valproic acid it is. Now valproic acid is an inhibitor of the UGT2B7 enzyme, specifically which participates in phase 2 metabolic pathways of many drugs. And it's one of the older generation anticonvulsants that doesn't induce the activity of the CYP450 enzyme system. All the other three listed options are well known to induce the CYP450 enzyme system, causing many drug-drug interactions. Now, even though valproic acid doesn't induce the CYP450 enzyme system, this does not rule out the fact that it can cause drug-drug interactions. Actually, it can significantly interact with lamotrigine, for example, increasing the risks of even life-threatening rashes. So be very careful when co-prescribing the two when managing convulsive disorders. Now, just like to emphasize the fact that serum levels need to be monitored when treating with valproic acid. Now, when managing seizures, for example, the normal reference range should be 50 to 100 micrograms per ml. Now, in the management of mania, for example, the corresponding range is 50 to 125 micrograms per ml. So pay attention to those for optimal clinical outcomes when managing those two conditions. Let's move to the next slide, please. And the question reads, Mr. POK, a 37-year-old male patient, presents to your neurology clinic complaining of a headache which has been occurring daily in the evenings for the past few weeks. Today, he presents because the headache has persisted for over an hour. He tells you in his own words, he feels like somebody is squeezing behind his eye. He informs your neurologist that the headache is only occurring on one side of the head, and he denies nausea, vomiting, and aura. He has had 2 such episodes in a span of 12 months, each one lasting about 2 weeks at a time, and he remembers vividly one was during spring. So the neurologist at your clinic notices Mr. POK is sweating, moving around a lot, and he has a runny nose. during this particular visit. The neurologist diagnoses a cluster headache. So my question to you is, which of the abortive treatments listed below would be the best for Mr. POK now? Would it be oral ibuprofen? Would it be oxygen therapy? Would it be triptan? Or would you consider administering verapamil? I'll give you 10 seconds to choose the correct answer. So oxygen therapy would be the best option. The standard for acute or abortive treatments for cluster headaches is 100% oxygen, administered at a rate of at least 12 liters per minute. Now, NSAIDs and triptans, like alternatives A and C, may be used, but the oral route of administration delays relief of onset in acute cases such as this one. So oxygen would be superior to them. Then I would like to emphasize that verapamil may be used as first line for prevention of cluster headaches, but it isn't indicated for abortive treatment of cluster headaches at all. Let's move to the next question, please. And it reads, Mr. JCP, a 64-year-old male, is being treated for MSSA pneumonia complicated by ARDS and ventilator dysynchrony due to agitation. Today, he is unusually acidotic and requires increasing vasopressor support. Currently, he is on 30 mics of norepinephrine infused per hour IV, 0.03 units of vasopressin infused per minute, and a continuous infusion of 12 grams of nafcillin over 24 hours. He's also receiving 70 mics of propofol per kilo infused over a minute continuously. Then he's also on lorazepam at a dose of 2 milligrams per hour IV. And for stress ulcer prophylaxis, he is receiving 40 milligrams of pantoprazole administered IV once daily. And because of the risks of thrombosis, the team opts to do thromboprophylaxis using 40 milligrams of enoxaparin administered subcutaneously once daily. Some of his vitals include a systolic blood pressure of 78, diastolic of 50, a heart rate of 105, pretty high. His body temperature is 98.6 degrees Fahrenheit, and he has a respiratory rate of 22. Some of his pertinent lab values include sodium levels of 145, potassium of 5.5, chloride of 102, bicarb of 17.3, a BUN of 32, serum creatinine of 1.7, AST of 337, ALT of 42, ALP of 120, and a total Bailey of 0.8. So my question to you is, which of the explanations listed below best explains Mr. JCP's deterioration? Is it hepatocellular injury from continuous infusion of nafcillin? Could it be a case of propofol infusion syndrome, abbreviated as PRIS? Or could it be a case of propylene glycol toxicity from the IV lorazepam he's receiving? Or is it a case of vasopressin-induced splanchnic and hepatic ischemia? I'll give you 10 seconds to choose the correct answer. is a case of PRIS. Now we know that Mr. JCP is receiving a large dose of propofol, and he has unexplained metabolic acidosis. I would like to prompt you to note the low bicarb levels, and we also notice that he has a worsening hemodynamics. There is hypotension in his case, and all these are characteristics of propofol infusion syndrome, PRIS. Now C is wrong, because we know that propylene glycol toxicity usually occurs with prolonged infusion of lorazepam at high rates, that is 5 milligrams per hour or greater, for more than 48 hours to be specific. We know that our patient is receiving it at a dose of around 2 milligrams per hour, so it doesn't add up, and thus it isn't the best answer for JCP's case. And we know that naphthalene hepatotoxicity is normally from cholestatic injury with elevated alkaline phosphatase rather than acute hepatocellular damage, which causes AST and ALT elevations. I would also like to add that vasopressin-induced ischemic events are mostly commonly related to infusion rates exceeding the 0.03 units per minute recommended by the Surviving Sepsis Campaign guidelines. So this does not apply to our patient. Now I would like to emphasize that propofol infusion syndrome, PRIS, is a rare, life-threatening adverse effect that has been associated with prolonged and high dose infusions of propofol. Now PRIS should be considered in patients with a sudden worsening of hemodynamics, hypertriglyceridemia, and even arrhythmias. Now, less common features may include elevated LFTs, even rhabdomyolysis can occur, acute kidney injury can occur, and even hyperkalemia. Now, if PRIS is suspected, propofol, in my opinion, should be discontinued promptly, and supportive care should be initiated. We know that there is no antidote available for PRIS, and patient survival is dependent on early identification and management of potential PRIS. I would just like to add that propofol contains EDTA, and it may result in zinc deficiency when infused or used for more than 5 days continuously. And there are even allergy issues. Remember, propofol should be avoided in patients with soy or egg allergies. So when you are using it for sedation, you have to put into consideration all those small bits of facts. Let's move to the next question, please, which reads, which pair of factors listed below can influence the pharmacologic effects of phenytoin, which is marketed as Dilantin, and the interpretation of measured serum drug levels? Is it potassium and bicarbonate levels? Is it blood urea nitrogen, BUN, and albumin levels? Is it sodium and albumin levels? Or is it albumin and creatine kinase levels? I'll give you 10 seconds to choose the correct answer. So the correct answer would be BUN and albumin levels, and I'll give you the reason why. The two main factors that can increase the free fraction or unbound concentration of phenytoin are albumin and BUN levels. Now, in patients with low albumin levels, there are less protein binding sites for phenytoin, and the end result is more free drug in plasma. Now, in patients with high BUN levels, we know that BUN can displace phenytoin from albumin binding sites through what we call competitive binding, thereby increasing the free fraction or unbound proportion of phenytoin. Now, the clinical relevance of this is that toxicity can result if those levels are extremely raised. Now, if a patient reports to hospital and on physical examination he appears phenytoin toxic, even if a normal lab assessment of phenytoin levels are reported in such a patient's case, that is, if he has low albumin levels or high BUN levels, then such laboratory results may suggest the drug concentration is in the normal range of 10 to 20. Now, simply reading the lab results and not putting them into context of the patient's situation could cause an experienced clinician to, for example, exclude phenytoin as the cause of the patient's presentation. Now, the truth is that the free fraction is elevated, and the only way to know that is by ordering a special lab which we call the free phenytoin level. Now, this will more accurately determine the influence of phenytoin on this patient's situation. Now, some clinicians will adjust phenytoin levels based on albumin or BUN to serve as surrogate markers of the likelihood of phenytoin toxicity. Now, I would just like to add that alternative A and B are not correct because sodium and potassium have nothing absolutely to do with the protein binding. So that's just a by the way to emphasize the fact that B is our correct answer in this particular case. Let's go to the next slide, please. It reads, which of the medications listed below shouldn't be co-administered with almotriptan? Is it diltiazem, ketorolac, tedizolide, or phenytoin? I'll give you 10 seconds to choose the correct answer. Tedizolide is the correct answer in this case, and I'll tell you why. Almotriptan, which is marketed as Axat, is a serotonin receptor agonist. It actually binds receptors 1B and 1D. And our drug tedizolide, which is marketed as Civextro, is an oxazolidinone antibiotic that has monoamine oxidase inhibitor properties. And concomitant administration of both drugs should be avoided due to the risk of elevated levels and effects of almotriptan. I would just like to add that both linezolide and tedizolide have monoamine oxidase inhibitor activities, and in addition to the antibacterial effects, they can cause clinically relevant drug-drug interactions with what we call the noradrenergic medications, and this can lead to far-reaching consequences. So don't co-administer those two. Let's move to the next slide, please. Our next question reads, Mrs. W.O.C., a 62-year-old female who experiences an exacerbation of a newly diagnosed pulmonary fibrosis which requires mechanical ventilation, is admitted at your hospital. She has a past medical history of bipolar disease, which she treats using valproic acid, and hypothyroidism, which she manages using levothyroxine. On day 4 of her admission, her primary nurse notices that higher infusions of her analgesics and sedatives are required to keep her comfortable. She appears more agitated and restless. Currently, she's on midazolam at a dose of 4 milligrams IV per hour, propofol at a dose of 60 mics per kilo per minute IV, morphine at a dose of 2 milligrams per hour IV, famotidine at a dose of 20 milligrams administered via NG tube twice daily, linezolid infused at a dose of 600 milligrams over an hour twice daily, ceftriaxone infused at a dose of 1 gram over half an hour once daily, and levofloxacin administered at a dose of 750 milligrams infused over 90 minutes once daily, alongside methylprednisolone administered at a dose of 40 milligrams IV thrice daily, valproic acid administered via NGT at a dose of 500 milligrams thrice daily, and she also receives 5,000 units of heparin subcutaneously twice daily, and they are also nebulizing salbutamol at a dose of 2.5 milligrams every 4 hours. Now, her most recent labs include sodium levels of 135, potassium of 4, chloride of 108, bicarb of 20, BUN of 24, serum creatinine of 1.5, AST of 15, ALT of 30, triglycerides of 1,100, total bilirubin of 0.7, and a lipase of 670. Some of our vitals include a systolic blood pressure of 165, diastolic 96, a heart rate of 112, pretty high. Her body temperature is 99.9 degrees Fahrenheit. So my question to you is, which of the medications listed below is likely the cause of Mrs. WOC's laboratory derangements reflected above? Is it heparin, propofol, valproic acid, or ceftriaxone? I'll give you 10 seconds to choose the correct answer. Propofol it is. Now we know that propofol is formulated as a 10% fat emulsion, which with higher infusion rates and or prolonged exposure can cause hypertriglyceridemia, and in extreme cases it can also lead to pancreatitis. Now answer A, heparin isn't a cause of hypertriglyceridemia induced pancreatitis at all. We know that short-term heparin use decreases triglycerides by increasing lipoprotein lipase, what we abbreviate as LPL activity, which results in chylomicron degradation. Now, heparin is often administered in combination with insulin in such patients. Now, ceftriaxone, on the other hand, especially in the young population, the neonates below age of 22 days of life, may cause biliary sludging and even gallstone formation. Now, this could precipitate pancreatitis, acute pancreatitis to be specific, if it occurred in an adult, and this adverse effect is more common after prolonged duration of therapy with ceftriaxone, and that would not be relevant in this particular case. Now, valproic acid can cause pancreatitis at any time and even with any dose through an unknown mechanism of action. Now, this is a very rare cause of pancreatitis, though. I would just like to add that valproic acid is one of these patients' home medications, and the fact that there is a temporal relationship between the patient's onset of signs and symptoms of pancreatitis and the initiation of propofol makes these cause and effect explanation more likely. Now, I would just like to add that during the use of propofol, routine monitoring, that's every 3 to 5 days of triglycerides, is recommended. Now, close monitoring of triglycerides is especially important in patients on therapy for longer periods or who are receiving high infusion rates or high doses. Now, if a patient develops PRIS, then propofol should be discontinued and an alternative sedative should be initiated in its place. Now, I would also like to emphasize that when developing a nutrition plan for such a patient, we need to remember that propofol contributes 1.1 kilocalories per ml, which can become clinically relevant in patients on higher propofol infusion rates. So pay close attention to that. And then I would also like to sensitize you to remind the nurses administering propofol that after 12 hours of propofol use, the remaining drug in the vial or the related tubing should be discarded. Remember, it's a fat emulsion and it could be oxidized to toxic byproducts. So for the safety of the patient, discard after 12 hours of being exposed to oxygen in the air. Let's move to the next slide, please. And the question reads, Mr. J and S, a 36-year-old man, is brought to your A&D after a road traffic accident. He is neither awake nor alert, and he remains unresponsive to any questions or stimuli. Your team establishes that he has a Glasgow Coma Scale score of 3. His only venous access is a 22 gauge peripheral venous catheter, and you have no past medical history available. Some of his vitals include a heart rate of 110, a systolic blood pressure of 165 with a diastolic of 80. His body temperature is 98.6 degrees Fahrenheit. He has a height of 70 inches and a weight of 80 kilos. He is endotracheally intubated and mechanically ventilated, and the respiratory rate is 15 breaths per minute with an oxygen saturation of 94 on 100% oxygen. After the trauma team assesses Mr. J and S, a head CT confirms traumatic brain injury. So my question to you is, which of the statements below regarding phenytoin administration in such patients is correct? Is it true that the maximum infusion rate of phenytoin is 150 milligrams per minute? Or is it true that phenytoin can be administered via intraosseous access, IO? Or is it true that phenytoin must be filtered with a 0.22 micron filter during the dilution process prior to infusion? Or is it true that phenytoin can be administered intramuscularly, IM? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. It can be administered via the IO access. Now, phenytoin must be infused with a 0.22 micron inline filter due to the risk of potential precipitation of the solution while it is being infused into the patient, not during the dilution process itself. Now, the maximum IV or IO infusion rate for phenytoin is 50 milligrams per minute, not 150. That makes answer A wrong. And the preferred route of administration during seizures is IV, intravenous. But if the IV route isn't available, it can be administered IO, intraosseous. Now, I would like to stress the fact that phenytoin should never be administered IM due to the precipitation that occurs in the muscles, and that can lead to unpredictable pharmacokinetics of phenytoin. Now, I would like to remind you that phenytoin is a hepatic enzyme inducer and will likely cause several drug-drug interactions. And when available, phenytoin should be considered as an alternative due to equivalent efficacy and improved safety during IV administration. Now, if no IV access is available, IM phenytoin may be considered. Now, I would like to emphasize that the IM volume for most patients usually exceeds 15 ml of the phenytoin, and it may require multiple sites of administration where you subdivide the dose into bits of 3 to 5 ml per site for the comfort of the patient. That's just a by the way. Let's move to the next slide, please. And the question reads, Mrs. JRM, a 30-year-old expectant female, has a history of focal epilepsy and is stable on phenytoin at a dose of 200 milligrams orally twice daily. So my question to you is, which of the statements listed below would be correct regarding the use of phenytoin in pregnancy? Is it true that phenytoin has been shown to cause fetal malformations and therefore this lady should stop the use of phenytoin? Or is it true that phenytoin has been shown to cause fetal malformations and this lady should start folic acid use? Or is it true that phenytoin has been shown to cause fetal malformations and our patient should initiate vitamin D supplementation immediately? Or is it true that phenytoin hasn't been clearly shown to cause fetal malformations? I'll give you 10 seconds to choose the correct answer. So B is the correct answer. Phenytoin has been shown to cause fetal malformations, and we should recommend this lady starts folic acid supplementation immediately. Now we know that phenytoin crosses the placenta and is associated with increased risk of fetal malformations, which include, for example, orofacial clefts or defects, cardiac defects, microcephaly, hypoplasia of distal phalanges, and so on and so forth. Now, phenytoin can be continued during pregnancy for seizure control, but this should be under the supervision of a qualified physician. Now, the risk of loss of seizure control should be weighed against the risk of fetal malformations before making that decision. And we know that phenytoin may induce folic acid deficiency, and folic supplementation at doses of 2.5 to 5 milligrams daily should be started even prior to conception, because that has been shown to reduce the number of fetal malformations in such cases. Now, phenytoin hasn't been shown to significantly affect maternal or fetal vitamin D levels that require supplementation, and that explains why answer C is wrong. So let's move to the next slide, please. And the question reads, Mrs. WKO, a 65-year-old female, presents to your neurology clinic with a non-traumatic intracerebral hemorrhage, abbreviated as ICH. My question to you is, which of the pharmacologic agents listed below would be the most appropriate seizure prophylaxis pharmacotherapy for Mrs. WKO? Would it be levetiracetam, phenytoin, valproic acid, or none of the above? I'll give you 10 seconds to choose the correct option. So none of the three listed drugs would be the best option. Although 10 to 15% of ICH patients have a seizure within the first 24 hours of presenting, seizure prophylaxis is not indicated. Now, seizure prophylaxis with levetiracetam, phenytoin, fosphenytoin is used in patients with severe traumatic brain injury for 7 days after the injury. If, however, a patient has a seizure or is seizing, then such a patient may receive antiepileptic agents, since in this case we are not prophylaxing but offering treatment. Now, in primary ICH, the prophylaxis or prophylactic use of phenytoin is associated with increased death and disability. Now, risk factors for development of epilepsy after ICH include stroke severity, cortical location of say a hematoma, and delayed initial seizures, if I remember well. Now, I would just like to underscore the fact that continuous EEG monitoring should be considered in ICH patients with depressed mental status that is disproportionate to the degree of brain injury. Let's move to the next question, please. And it reads, which of the anticonvulsants listed below is known to cause hyperammonemia, which can sometimes lead to the development of encephalopathy? Is it carbamazepine, valproic acid, phenobarbital, or lacosamide? I'll give you 10 seconds to choose the correct answer. So valproic acid is the correct answer. Now, valproic acid and its derivatives, which are available in the market as Depacone and Depakin, are anticonvulsants used in the treatment of seizures as well as bipolar disorder. But we know that they can cause significant elevations in ammonia levels, which can lead to encephalopathy. Now, answer A, carbamazepine, is associated with SJS or TEN in patients who are HLA-B star 15 or 2 allele positive. That's those who have HLA-B star 1502 genetic polymorphism. So that makes answer A wrong. Then lacosamide is an anticonvulsant that has been associated with cardiac conduction abnormalities. In literature, they say it can cause PR interval prolongation, it can cause AV block, and it can even cause, in extreme cases, ventricular arrhythmias. Now, answer C, phenobarbital, is classically associated with sedation, and being a CYP enzyme inducer, it can cause many drug-drug interactions. But it has nothing to do with hyperammonemia. So, ladies and gentlemen, my highly esteemed viewers and listeners, that brings us to the end of part 47 of our Pharmacotherapy MCQ series, which majored in neurology. If this video benefited you in any way, I would like to remind you to give it a thumbs up and to like it, and to share it widely with your peers. And if you haven't yet done so, I would like to humbly urge you to subscribe to my YouTube channel. I would like to promise you all that the best is yet to come. I would like to thank you very much for viewing and listening to me. I sincerely appreciate your partnership and your continued support and kind collaboration, and I look forward to interacting with you all in the next video, which would be part 48 of our pharmacotherapy MCQ series. Thank you very much for always being there for me.